And we are very proud of our dietetics team and our dietitians, Ms. Swaha and Ms. Chitra, the organizing team of the webinar. We have got over 2,300 participants, which itself shows that this program is a great success. With this in view, Curie Hospital and IDA have put together a course to share our expertise and knowledge in nutrition to the patients with renal diseases. We are a super specialty hospital focusing on urology, nephrology, and uro-oncology, equipped with the Da Vinci robot and headed by the India's senior-most urologist, Dr. P.B. Shivaraman, and consultant urologist and robotic surgeon, Dr. Krishnan Sriram. We aim to be the premier institute for renal diseases. I take great pleasure in introducing our speakers. The second speaker would be Ms. Chitra Mahesh, consultant dietitian, Chennai Meenakshi Multi-Speciality Hospital, who is going to talk to us on Global Leadership Initiative on Malnutrition, a new definition. And our international star speaker, Dr. Krishnan Sriram. He is currently a tele-intensivist with the US Veterans Affairs Telemedicine Service at Chicago, USA. His former positions include Division Chair of Surgical Critical Care as well as Director, Nutrition Support Team and Surgical ICU at Cook County Hospital, Chicago. Dr. Sriram is a member of various societies and serves on the editorial boards of several journals. He has conducted educational programs in Asian countries adapting Western standards to local conditions. His interests include early enteral feeding, oral nutritional supplements, micronutrients, team building, and utilizing telemedicine technology, areas in which he has several publications and presentations. We are proud to have you here, sir, in our webinar. And over to Dr. Sriram now.
Thank you very much. I'm quite happy to be here to share my thoughts with you. And I think the first thing I'm going to do is I'm going to share my screen with you. And you tell me if the screen is okay with you right now. Is it coming out all right?
Yes, sir. Yes, sir. We are able to see the screen.
You're able to see the screen?
Yes.
Okay, just 1 minute, please. Just 1 minute. Okay. Do you see my title slide okay?
Yes, sir. We are able to see.
So, my friends, I'm very happy to be speaking to over 2,000 people, I'm told. And my job this evening is to give you an update on nutrition therapy in critical care. Now, I can tell you ahead of time that it has absolutely nothing to do with COVID alone, because as you know that we have been overdosed with webinars every day for the last 2 months. So I've got to make it very interesting for you, not specifically to COVID, but tell you what is actually new in critical care for the last 1 or 2 years. Now, there are a few disclosures that I have to go through. I have nothing pertinent to this presentation, no compensation of any kind, product names will not be used, and no endorsement of any specific product or company. Now, I have a lot of things to actually cover, and my objectives in this presentation are to understand that muscle wasting or sarcopenia occurs in critically ill patients. And this muscle loss is one of the main reasons why critically ill patients die. I want you to also understand that to attenuate or to decrease the protein catabolism, early enteral nutrition should be used, and I will discuss easy strategies for increasing the tolerance to enteral feeding and why parental nutrition should be used judiciously and minimally. Emphasize the need for continuum of care of the patient even after discharge from the ICU or from the hospital. And although not specific to COVID, the general principles of nutrition therapy in critical care are the same. All statements I make are justified and supported by society guidelines and publications in reputable journals, because as you very well know, there's a lot of misinformation that keeps circulating around here. Now, in an ICU patient, there are many nutrition disorders that occur. Malnutrition or undernutrition as we traditionally understand it, frailty and sarcopenia, overweight and obesity, which is a sign of inflammation, which has inflammation, micronutrient abnormalities, refeeding syndrome. Therefore, the very fact that a patient is in the ICU for more than 48 hours means that the patient is at risk for malnutrition or is already malnourished by the definitions that we understand, irrespective of any screening or assessment tools. Now, my friends, if we have a patient who comes to the ICU with a diagnosis of head injury, and then the head injury, the physician say, I'm not going to manage that, that's medical malpractice. Similarly, if you have a patient in the ICU with a diagnosis of malnutrition, then that malnutrition has to be addressed. The documentation of malnutrition using various guidelines, various definitions about which you'll hear more in this and the subsequent presentation is very important, because once the documentation is done, then immediately you will find that you will have to treat that irrespective of what anyone may say or the family or any physician may say, that diagnosis will have to be treated. Now, the traditional definitions of malnutrition are based upon weight loss and body mass index, but the new global leadership initiative on malnutrition, about which a subsequent speaker is going to give you a really fantastic talk, we'll discuss this a little bit more in detail to tell you that malnutrition by definition, whether you pick it up by subjective global assessment or the new GLIM criteria or whatever assessment you use, must be recorded and must be addressed in the hospital within 24 or 48 hours. And this malnutrition diagnosis is very important in older patients, post-op patients, trauma, bed injury, brain injury, bed rest. Just the fact that the patient is at rest results in muscle loss. And there are some nice terms that have come out recently. Sarcopenia, we all very well know. Sarcopenic obesity, the obese patient who looks fine but actually has muscle loss. And the term myosteatosis, which is discussed in great detail in a publication just in April of 2020, is when the muscle actually looks to you by anthropometric measurements pretty good, but actually most of the muscle is only fat, steatosis. The diagnosis is not easy, but ultrasound of the quadriceps femoris muscle in intensive care units is something we've been popularizing. But we can do a functional assessment with hand grip dynamometry. The last bullet point is frailty in obesity. It seems as if it is not, it seems counterintuitive to think that an obese patient would be frail. And the reference I have quoted here is available online, actually tells you that the obese patient just looks to be well nourished using the traditional way by which we observe patients, but actually they are quite frail. But when you have loss of the lean body mass, 10%, 20%, well, the patient may still live with poor wound healing and decreased immunity, increased infections, with 30% maybe infectious complications. But when 40% of the lean body mass is lost, 100% of those patients die. So it behooves us to make sure that sarcopenia or muscle loss is minimized. And for that, we must understand also that in normal starvation, fat is broken down, and hence the ketosis that occurs in our mouth when we go back from work. But in sepsis, trauma, cancer, bed rest, GI and non-GI surgery, it is the muscle that gets broken down at alarming rates. It is an auto-cannibalism. And the muscle is needed to provide the 150 grams of glucose, which is the minimum that we need every day. And for providing the 150 grams of glucose, you have to break down 675 grams or close to a kilogram of protein. Kilogram of lean body mass is actually broken down every day in the ICU. Now, in older patients, as you might see in this slide over here, as the patient gets older, the muscle becomes smaller and smaller. And that can be seen on CT scans, where in the older patient, you will find that actually on a CT imaging, the circumference is very large, but most of it is fat and very little of muscle. And it is also the strength that is reduced in various compartments in the body. It is not only muscle mass, but also muscle strength. Having now appreciated the fact that we have sarcopenia or malnutrition in the majority of ICU patients, we have to now discuss how much of protein and how much of calories we should give. This study, which was published almost 20 years ago, shows that there is a calorie death in many ICU patients. At that particular time, patients were not fed for up to 3 to 4 days. And even though the prescribed energy was 1800, you will find that the patient got far less than that, and it took several days before the patient reached the prescribed energy intake. And when that happens, you will find that there is increased mortality, increased morbidity, and actually death also occurs when you have a calorie debt. So our job is not to have any calorie debt at all. Longer ICU stays, increased days on mechanical ventilation, increased complications, and also death. So we don't wait for 3 days anymore. We start feeding within 1 to 2 days as best as we possibly can. The update on energy requirement is that you don't need predictive formulas. Don't use formulas like Harris-Benedict equation, which is about 125 years old, and use rule of thumb of 25 to 30 kilocalories per kilogram of ideal body weight. Now, very often people ask me about indirect calorimetry. It is not practical, it is not cost effective, and we can discuss this more in the question and answer hours. You'll find indirect calorimetry is mentioned often in some of the Western guidelines, but even in North America, very few hospitals use indirect calorimetry for reasons that I will explain later. The Europeans are very fond of it because it's available freely and the government pays for most of these tests. When higher protein requirements are met, the survival is similar whether you use hypocaloric feeding, which is 23 kilocalories, or eucaloric, 29 to 30. In other words, the calories are not that important anymore as long as something is given to the patient initially and then you reach the caloric goals. But what is important is actually the protein. The new evidence is that you need 1.2 to 2 grams of protein per kilogram of actual body weight. In the obese patient, as you can see on the slide, you may need more protein. The European guidelines will tell you go up to 1.3. I still don't know why they say just 1.3, but the North American guidelines, which I strongly believe in, says that you can go up to 2 grams of protein per kilogram per ideal body weight. Now, don't let anybody tell you that giving a high protein results in renal insufficiency or kidney failure. Does not happen. Don't let anybody try to tell you that giving a high protein affects oxygen dissociation and oxygen utilization. Those are all animal experiments, very old, and they're not substantiated by the North American guidelines, which I have referenced on this slide. You will also hear the term permissive underfeeding. Permissive underfeeding is acceptable only as a starting point. In other words, the benefits of enteral nutrition at very low rates of, let's say, 10 to 15 cc's an hour, the so-called trophic feeding, is because it attenuates or cuts down the stress response in the protein catabolism, and it maintains the gut defense. It facilitates the maintenance of the premorbid microbiome. And the reason why low calories are used initially is you can assess the patient for gastrointestinal tolerance. You can avoid refeeding syndrome, avoid hyperglycemia. And if the protein goals are met either by the protein in the formula that you're using or by addition of extra protein to the enteral feeding, then advancing to a caloric goal may be less important. And our job is to advance as tolerated to avoid the calorie and the protein debt. Now, some of you may say, how are you sure you are right? Well, it is not my opinion. This is the opinion of the major societies of high protein. However, to be very frank, this is a paper published about 3 weeks ago where they reviewed all the publications for and against the high protein diet. And it gives you a practical, what's called a pragmatic approach based upon current evidence and not individual opinions. We don't want doctors or dietitians to say, oh, this is what I believe. I believe in it. The I is no longer important in clinical practice. It's got to be what societies believe and what randomized randomized studies will actually show. And to that, I can tell you that the major study that is going on, the effort study, we really wait to see those results. It's a multi-center international randomized control study comparing high versus low protein in critically ill patients. And once these studies, I would say, because this is not the only study come out, we will be able to give you a categorical opinion whether high or low protein should be used in critical care. But for the time being, we follow the society guidelines of using a high protein. Now, in the ICU, we see metabolic complications, mainly potassium and phosphate and magnesium, which are intracellular ions. When glucose is metabolized, these go into the cell, especially when insulin is given. And hypophosphatemia is a major component of refeeding syndrome. Very often it is not checked. I cannot imagine running an intensive care unit without checking phosphate levels. Fortunately, phosphate as an intravenous form is available in India and various Asian countries. We check the BUN and creatinine, liver-associated enzymes, and triglycerides are also included when parental nutrition is given. But you can notice right away that serum albumin is not even checked. It has no predictive value. We don't use it either to diagnose malnutrition or to follow the success of malnutrition. Now, you'll ask me, what is early enteral feeding? By definition, for the various societies, it is 24 to 48 hours. 48 hours maximum is what's called early enteral nutrition. And the benefit is, as I mentioned earlier, it maintains the GI tract function, the contractility, the mucosal integrity. The largest immune organ in the body is the GI tract. It preserves the gut microbiota, avoids parental nutrition. It is certainly physiological and natural. I wasn't born with a subclavian or an internal jugular catheter in me to receive parental nutrition. The nature made the GI tract for what it is worth to be the natural and the most physiological way of feeding a patient. And we have to be sure that by not feeding the gut, we not only lose the surface area of the small bowel, but we also don't use the role of the small bowel in maintaining the immunity of the body, because the mucosal associated lymphoid tissue is one of the major immune organs in the body. By starting enteral feeding early, you avoid parental fluids and parental nutrition, of course. Intestinal edema is decreased, early mobility is facilitated, pulmonary and vascular complications are decreased, but most important, there is an attenuation of the stress response and loss of lean body mass, which never occurs from parental nutrition. Now, there are some studies that have compared parental and enteral feeding, and this is a study 20 years ago in 2001, almost 2,000 patients. They showed very clearly that regardless of cancer or nutritional status, infection risk goes down. And here they compared enteral and parental, but there was no difference in mortality. A couple of years later, this study by Dr. Halen came out, which showed in a meta-analysis of 14 prospective studies that there was definitely a reduction in the infectious complications that were shown earlier, but they showed a 32% reduction in mortality by using early enteral versus delayed enteral. So we are very clear in our mind that early feeding between 24 to 48 hours is here to stay. Therefore, we should now go on to how do we give it. Now, there are various methods of feeding a patient, which most of you are familiar with, but please avoid bolus feeding in the critically ill patient. ICU patients should never be given bolus feedings every 6 hours, every 4 hours. The glucose fluctuations are very high, and the glycemic variability is so high that it is a nightmare to maintain the glucose levels with insulin, and it is directly related to mortality. The pump assisted can be continuous feeding, which is the way to feed all ICU patients. You can change it to intermittent or cyclical, 4 hours on, 18 hours on. So various things can be manipulated by using pumps. If you don't have a pump, it does not matter. You can still manage the patient. It only means it is more difficult. But always initiate at full strength. There is absolutely nothing to substantiate the view of some folks that you can dilute the enteral feeding more. Instead of giving 6-7 scoops, you add only 2 scoops and try it out. No, that does not work. You start everything at full strength. And I would also urge you to use volume-based feeding. Volume-based feeding means that you write an order to say that I need so many cc's of enteral feeding to go within 24 hours. Now, if the patient should go for a CT scan and come back 2 hours later, then the nurse is empowered to increase the rate of enteral feeding without a physician's approval. And such formulas, just such algorithms are easily available. Many studies, as quoted in this slide, show that there is no protein or calorie debt when you do that. Actually, you manage to give more protein and calories to the patient. There is absolutely no adverse effects on glucose control. It is cost effective and your patients can be extubated sooner. Therefore, please change your order writing to volume-based feeding, and there are several publications available on this. Now, we go on to the route of feeding. Should we feed into the stomach or into the jejunum? Years ago, we made a big deal about intrajejunal feedings, but the new guidelines clearly states that intragastric feeding is possible in the majority of ICU patients. But there are certain conditions like severe gastroparesis and diabetes or uremia, or when you have gastroesophageal reflux, when you know that there's a duodenal obstruction, or at the time of laparotomy, when the patient's abdomen is open, it takes only a few minutes to put a tube into the jejunum. Especially useful in patients who have to go back frequently to the operating room, debridements, abdominal wound closure, and things like that. So sometimes preemptive jejunal access may be necessary, but in the majority of patients, you actually don't need it. And don't let anybody tell you that pneumonia is less with intrajejunal feeding. This study, called the Enteral study, again a multi-center randomized control study, showed no difference in pneumonia in mechanically ventilated patients. And this study, again, 2 other studies have compared intragastric and intrajejunal, and several other randomized control studies have confirmed that energy delivery, mortality, length of hospitalization is no different between intragastric or intrajejunal feedings. In the recent COVID epidemic, it is almost impossible to get an intrajejunal tube to a patient, so to limit the contact with the patient, and transportation to the X-ray department if necessary, and intragastric feeding has been shown to be quite successful. Now, gastric residual volume. How often do we as physicians and nutritionists go back to the ward the next morning and the nurses have stopped the feeding because the gastric residual volume is high? We ask the nurse, how much? High. And the reply is 150 cc. That practice has been given up almost 15-20 years ago. There is no relationship between gastric residual volume, aspiration pneumonia or pneumonitis, ventilator-free days, organ failure, and studies have shown that there is actually no need to measure it at all. So the Aspen guidelines say we suggest that GRBs not be used as a routine practice pattern in ICUs. But if you want to use it, if you want to convince your nurses to go from 150 to 250 to 350 and then finally to 500, then they say up to 500 ml in the absence of other intolerance, you do not need to hold enteral feeding. This is a cultural difference that all of us have to work on, not only with doctors, but also with nurses. The gastric residual volumes has been given up. Now, in selective conditions, I agree with you, as mentioned earlier, where we need intrajejunal feedings, you can use, check gastric residual volumes, diabetes, urinary gastroparesis, or certain medications like narcotics that empty, that delay gastric emptying, patients with GE reflux. And if the GRV continues to be elevated in prone positioning ventilation, which is very common now, about which I'm going to talk about a little bit later, consider the preemptive use of prokinetic agents, metoclopramide, in doses of 5 to 10 milligrams. And this study in about 60 plus patients in a community hospital showed that elimination of gastric residual volume measurement had no adverse effects and no difference in adverse effects in emesis, diarrhea, or glucohomeostasis. And the risk to reduce the risk of aspiration preemptively in those patients in whom you think the aspiration risk is high, make sure the head end of the bed is elevated, continuous feeding, and pro-motility agents. And this again, I'm quoting again from the Aspen, American Society for Parental Nutrition, Society for Critical Care guidelines. Couple of words about bowel motility and ileus. You don't need bowel sounds for initiating enteral feeding. That practice again given up 20 years ago. This is the 2016 wording. Overt signs of contractility, passage of flatus, or bowel sounds are not lethal. Another problem is GI anastomosis. We have patients after pancreatic surgery in our hospital who are on liquid diet the same evening. So don't let anybody tell you that just because a surgeon has done a intestinal anastomosis or an intestinal or a colonic anastomosis, you need to starve the patient. The colon surgeons are very easy to convince, and they start feeding the patient within the next day itself. If the rectum can actually tolerate stool going through the anastomosis, why can't the upper GI tract tolerate saliva and a little bit of feeding? Anastomosis actually heal better with early enteral feeding, less anastomotic leaks. Therefore, there was no contraindication to feeding the patient when a GI anastomosis is done. And if you are giving a liter of enteral feeding to a patient with so many liters of secretions in the body, then enteral feedings will not produce any adverse effects at all. Well, can we use enteral feeding in hypotensive states? Absolutely, yes. Earlier we didn't do it, but now we are told we can. And we do it with caution in patients who are stable and low dose of vasopressors. And the mean arterial pressure is now 50 millimeters of mercury. So if the mean arterial pressure is 50 millimeters of mercury, it is absolutely safe to start enteral feeding at slow rates initially. But when catecholamines, as listed on this slide, so-called pressor agents, norepinephrine, phenylephrine, dopamine, are initiated, then you should hold off on it to see whether the patient can tolerate it or whether it can be increased. And when increasing doses are required to maintain the blood pressure, that is a time when we are trying to save the patient's life, and enteral feeding is less important at that particular time. Now, there are two other things which are based on personal observations, not published, but many doctors agree with me, many intensivists agree with me. You check serum lactate levels periodically, even though there are other reasons why lactate may be high. And if that is going up and up and up, perhaps you should be feeding a patient in the hypotensive state. Or if gastric residual volumes keep on increasing, that's a surrogate marker that we perhaps should be careful about hypotensive states, and we should not be feeding the patient, and maybe we should go on to trickle feeds at a slower rate. This paper published just in about a month ago on enteral feeding in sepsis showed that it does not worsen hemodynamic instability. The median dose of vasopressors did not increase significantly. So delivering early enteral feeding during septic shock is not associated with worsening hemodynamic instability. And this statement is supported by all the recent COVID webinars that I've seen during the last month and a half. Now, can we feed a patient with an open abdomen? For those of you who are not familiar with an open abdomen, it means that in a patient with peritonitis or certain conditions where even there's no previous operation in trauma, we surgeons decide to leave the abdomen open. When you leave the abdomen open, it doesn't mean this patient will need parental nutrition. It can be safely used in these patients, even when there's edema of the bowel, even when you apply negative pressure wound dressings, vacuum-assisted wound dressings. We prefer to have an intrajejunal tube, but it is always not necessary. But one thing is, because a lot of fluid is lost from the abdomen, you need to give 15 to 30 grams of protein per liter of exudative fluid that is lost. A few words about enteral feeding in the prone position, about which all of us are talking about. Many of our COVID patients recently are being nursed in the face down or prone position. And in order to explain, the supine position, which is how most of us sleep with our face up and our toes pointing upwards. This is the heart here, and this is the lung in black. But when you prone the patient with the face down, you can see the heart moves down, and therefore there is more of lung to do the work that it is designed to do. So prone positioning is very common in many of the COVID patients. I'm very happy to tell you that the group in Apollo Hospital in Chennai has published this fantastic paper to show that prone positioning is absolutely feasible in India, in an Asian country, in mechanical ventilated critically ill patients. Intragastric feeding is feasible, well tolerated, and the calorie and protein delivery is similar to that in the prone position. It is absolutely similar to the new COVID guidelines. Now, when do you use parental nutrition? Well, only in a patient who's severely malnourished with an absolute contraindication for enteral feeding, high output enteral fistulas, should you use it. And do everything possible to give the patient enteral feeding, only then do it. In other patients, you can wait up to 5 to 7 days. Now, the guidelines will say 7 days, but that is applicable to young trauma patients or healthy older patients. Most doctors won't believe that we should wait for up to 7 days of giving the patient nothing at all. It is true, a well-nourished patient may be able to tolerate it, but many times we really don't know. But if the patient screens positive for malnutrition, then you can start parental nutrition a little bit earlier. However, make sure that all components of the parental nutrition are used. There is absolutely nothing called partial parental nutrition, a very popular term in India, doesn't exist anywhere else in the world, never gives them just amino acids alone or lipid emulsions alone, has no indications at all. Now, micronutrients are another thing. Micronutrient deficiencies are very common but not recognized. No need for lab tests. It must be an integral part of nutrition therapy. Enteral formulas have a lot of micronutrients. And this is a paper in which I was proud to be a partner with, a global leadership, not a GLIM, but a global leadership initiative for parental nutrition, micronutrients, where we have recommended that physicians must be very sensitive to adding micronutrients, which means both multivitamins and trace elements anytime parental nutrition is used in a critically ill patient. Now, the last couple of slides, don't ever forget that our job is not only in the intensive care, the care unit. Now, this is a slide that I took from the ERAS, or the Enhanced Recovery After Surgery protocols, where right from the pre-admission up to the time the patient goes home and a 30 to 90-day follow-up at home, we should be thinking about the patient's nutritional status. And although this slide is specific for surgery, in any medical condition too, any patient who leaves the ICU and goes to the ward, from the ward to the home, must always be followed up and can be advised that nutrition is very, very important for recovery, whether you are recovering from a medical condition or a surgical condition. And the nutrition therapy guidelines for critical ill patients in the Asia Pacific region has been published in Clinical Nutrition, and there are a couple of people from our own country in this fantastic publication. Many of these publications are available for free online, but if it is not available also, not to worry at all. If it is not available, not to worry, because I'll be able to give it to you. Just one more statement that I want to make is that you can feel free to contact me for any advice that you may probably need in terms of managing patients on enteral or on parental nutrition. So I'm going to stop sharing my screen now, and we have another speaker.
Thank you very much, sir, for the enlightening speech. And it was really very nice to hear about all your, each and everything regarding the enteral feed in critical care, and especially this prone position in COVID and how it helps, and the early start of feed in jejunostomy patients, anastomotic patients, and all that. It was really nice.
Sure,
And
just wait for 1 minute, and I'm going to get the other speaker over here.
yes,
And let's see whether I can share the screen again. Okay, just wait for 1 minute, and I will try to get this going for you.
Yes.
Okay, here is a slide. Can you see her slides now?
You're not able to see the slides, sir.
Okay, so let's okay, now you can, now I'll share the screen.
Yes, sir.
Okay, you can share the screen. Okay, and now we go on to this. Let me say share. And how about now? Can you see the slides now?
Yes, sir, we are able to see.
Wonderful. Wonderful. I'm going to step out now, and we will have Ms. Chitra Mahesh present her nice talk.
Thank you very much, sir. Now over to Ms. Chitra Mahesh, consultant dietitian at Chennai Meenakshi Multi Speciality Hospital. Welcome, madam. Over to you now.
Thanks, Dr. Rupa. I would like to begin my I would like to begin my presentation with a small disclosure. We have not started the new global leadership initiatives on malnutrition in my hospital. I'm going to be referring to this as GLIM in my presentation. My brief presentation deals with how we can simplify the definition of malnutrition, leading to early documentation and initiation of therapy. The diagnosis of malnutrition remains evasive. There are numerous definitions, mostly based on weight. Most often, there is an overlap between screening and assessment. It is not well appreciated that the term malnutrition may have different connotations to different people. The problems you often face with definitions of malnutrition based on weight are: many patients do not know their pre-morbid weight. Getting accurate weights in patients continues to be a problem. There can be fluctuations in weight due to fluid imbalance, and disease-related malnutrition may be missed, especially in obese individuals. Nutritional screening is done on patients within 24 to 48 hours after admission in most countries. While regulatory bodies insist on initial nutritional screening, not much emphasis is given on reassessment. But patients may get malnourished during hospitalization. For example, if a patient who is well nourished in the initial screening goes on to become malnourished during the hospital stay, and if the reassessment is not done, then the diagnosis of malnutrition and the intervention will be missed. The GLIM criteria was designed to pick up these at-risk individuals. It avoids being overconfident in relying on patients' self-reported histories and laboratory values. Depending on weight loss alone may result in missing malnutrition diagnosis. So members of many clinical nutrition societies came together to develop a core diagnostic criteria for malnutrition in adults in clinical settings. More than 55 criteria for diagnosing malnutrition were considered, and they came up with 5 top ranking criteria called as GLIM criteria. Most of these, like unintentional weight loss, low body mass index, and loss of lean body mass, are familiar to us. What is interesting is not only is food intake included, but assimilation of nutrients by the patient is also included. Disease burden is also included, and a clinical assessment of inflammation is essential. This is the GLIM table. This is a two-step approach. It helps in diagnosing and grading the malnutrition. The first step is screening to identify at-risk status by the use of any existing validated screening tool. Second step is the assessment with the help of the 5 GLIM criteria that are grouped under phenotypic and etiologic components. I will spend more time on assessment in my next slide. After the assessment, the diagnosis of malnutrition is done. What is unique about GLIM is we need just one phenotypic criterion and one etiologic criterion to make the diagnosis. While phenotypic criteria grades the severity of malnutrition into stage 1, which is moderate, and stage 2, which is severe, the etiologic criteria helps us to plan interventions. This slide tells us that the GLIM assessment depends heavily on a subjective evaluation of the patient. The phenotypic component comprises of unintentional weight loss, low body mass index, and reduced muscle mass. The etiologic component comprises of reduced food intake or assimilation, inflammation, and disease burden. I'm going to be spending a few minutes on each criteria. Weight loss and BMI can be obtained by basic anthropometric measurements and the detailed history collected from the patient or his family. Reduced muscle mass or function can be assessed both clinically as well as with the help of some imaging studies like CT or MRI. Hand grip dynamometer is a simple, useful tool that can be used by the bedside to assess muscle strength. But if the patient is unresponsive, this cannot be done. I would like to emphasize the importance of reassessment at this point once again. We should remember that patients can also develop ICU-acquired weakness resulting in muscle wasting, which will be missed if reassessment is not done. Reduced food intake can occur for several reasons that we are familiar with. Problems with diarrhea and GI losses may also compound the problem. There could be a chronic or an acute disease-associated malnutrition which needs to be analyzed. However, what is more difficult is to clinically assess the presence of inflammation, about which we will discuss more in detail in the next slide. Since the inflammatory component will have both diagnostic and therapeutic implications, it is a priority to appreciate the presence or absence of a systemic inflammatory response. Now, if you ask me whether it is easy to assess the presence of inflammation clinically, the answer is both a yes and a no. No, it's a no because there are no specific clinical markers to indicate inflammation. It's a yes because there are some non-clinical markers like fever, hypothermia, and tachycardia that can indicate inflammation. Some laboratory tests that are routinely done for other purposes can also serve as non-specific indicators of inflammation like hyperglycemia and leukocytosis. Also, the visceral proteins that were traditionally used as markers of nutritional status serve as good markers of stress response and inflammation. Also, normal levels of visceral proteins does not mean that there is no malnutrition. If the patient is found to have ICU-acquired weakness, there is a strong chance that inflammation is present. However, if you want to confirm your clinical findings with laboratory tests for record purposes, then C-reactive proteins and interleukin-6 tests are the tests to be done. As a sum up, let us look at the advantages of the new GLIM criteria. It's prepared by an international consortium. It helps to standardize definitions for detection and intervention. It helps to standardize publication. It expands the ability to detect and document malnutrition by not depending on weight loss alone, but including etiology. It suggests the importance of muscle wasting even in obese individuals. There is no scoring used. And it grades malnutrition into just two grades, that is stage 1, which is moderate, and stage 2, that is severe. Now I'm going to take you through a few papers that have validated the usefulness of GLIM criteria. This recent review paper, published a few weeks ago, shows the usefulness of GLIM in diagnosing and treating malnutrition in oncology, trauma, and heart failure patients. This is yet another paper that has validated the usefulness of GLIM in cardiovascular disease. This is a study done on over 900 patients with heart failure and acute coronary syndrome. The assessment tools suggested by SM guidelines were compared with the new GLIM. They found out that GLIM could predict physical function and mortality in cardiovascular diseases. This is another interesting paper that was done in older patients. Here, the GLIM was compared to other tools. It was found that the GLIM could pick up more malnutrition when compared to other tools. It picked up 19% of malnutrition, while the other tools picked up only 11%. This implies that in 8% of patients, the diagnosis of malnutrition would have been missed if GLIM criteria were not used. An often asked question is, how does GLIM compare with the traditional SGA? This Canadian study, done on over 1,000 patients across 18 hospitals, showed that GLIM has both high sensitivity and specificity for diagnosis of malnutrition. I would like to conclude by saying that GLIM criteria is designed to standardize and simplify the diagnosis of malnutrition. It is good for auditing purposes. It is easy to use and administer. It can be adopted in all hospitals, both big and small, and it is supported by all major societies, including the recent COVID recommendations. I'm providing you with my email information. All the references I've used here are available online. But if you should need more information, please feel free to contact me. Thank you.
Thank you, madam, for the nice talk on GLIM. We have one question from our participants. They need to know, has GLIM criteria been validated for general community use? This is the question from one of our participants, madam.
No, GLIM criteria was designed for adults in critical care settings. It has not yet been tested on community patients, community settings.
We have few more questions for Sriram, sir.
Yeah, so we are going to move some chairs around. We are going to move some chairs around so both of us can be seen. And,
sure, sir.
And if there are any more questions, what we will do is, so should I stop sharing my screen now?
No, sir. I just asked these questions. These are a few questions which has been raised among our participants. What is the role of soluble fibers in enteral feeding, sir?
Yeah, so soluble fibers are very important for maintaining the integrity of the colon. The fibers, as you know, are both soluble and insoluble. Soluble fiber gets fermented in the GI tract to short-chain fatty acids, butyrate, acidoacetate, and propionic, and it maintains the colonocytes, and it helps the absorption of sodium and water through the colon. So it is quite important that we use enteral feeding which contains soluble fiber. They are either inherently present in the formula or they are also commercially available to be added to the enteral feeding. But remember, they can block small bore feeding tubes.
Thank you, sir. The next question is, explain the role of preoperative parental nutrition.
Yeah, there is very little role for preoperative parental nutrition. Okay, very little role. The earlier studies showed that if you want to give preoperative parental nutrition, you got to give it at least for 7 to 10 days. And earlier studies shown that in the very severely ill patients, the mortality was higher with preoperative parental nutrition. So there are certain conditions in whom you may have to give parental nutrition. I perfectly agree with you. But it is not only for the protein, but it is also to correct the micronutrient deficiencies. There are a couple of publications that I can send you later, where it shows that when you give parental nutrition, the muscle actually does not regain anything. There is fat in the muscle. So there is a limited role of preoperative parental nutrition in selected patients. No one seems to know exactly how long, but a reasonable guess is maybe 7 to 10 days in a very in a severely malnourished patient, but no strong evidence that it should be used in every patient. That is why we do our best. We do our best to give it enterally. Example: somebody with a carcinoma of the esophagus and they cannot eat, then it is wise to put in a jejunostomy first, operatively, feed the patient enterally for a few days, and then do surgery on the patient. Okay? So preoperative parental, there is a role, but we have to be careful on how to do it.
And the next interesting question is it all right to use clear liquids alone for pre-op carbohydrate loading?
No, there is no evidence at all. Clear liquids is better than doing nothing. I agree with you. At least the patient will have some fluid. But then pre-op carbohydrate loading should be very carefully looked at. You have to use whatever product has been studied. The maltodextrins that are available in the market, you have to be sure what kind of maltodextrin and what is the glycemic index of the maltodextrin. Now, just to say that you can use coconut water for preoperative carbohydrate loading is not really something that can be accepted because it is not really published. So every product has to be checked for the gastric emptying, and only then it can be substantiated. The literature always will quote the exact product you use, mainly because maltodextrins may have various kinds of linkages. So, but when you give honey or sugar with coconut water, that is not preoperative carbohydrate loading. As far as the literature today exists, Now, if somebody is doing it and they can show all the benefits of the ERAS protocol with using some other thing, then that is fine. But all I can say is it is not published, and we should not say that we are following the ERAS protocol and pre-op carbohydrate loading when all we are doing is giving coconut water. That would be scientifically wrong.
Thank you, sir. And are there any special suggestions for enteral tube feeding in mechanically ventilated patients, sir?
Well, in mechanical ventilated patients, you need a feeding tube. As simple as that. There are no specific suggestions of. They have to be fed. Obviously, they cannot take anything orally. Small bore feeding tubes are important. Size 10 or 12, not the usual heavy-duty polyvinyl chloride tubes that are very popular everywhere. So the tube has to be a soft tube put on the nose. And in a mechanically ventilated patient, the access is very important. But I would also tell you that there is absolutely no role to give pulmonary formulas for mechanically ventilated patients. I won't bore the audience with all the details, but there is no evidence to show that a high-fat, low-carbohydrate diet is needed for pulmonary problems, mechanically ventilated or non-ventilated patients. So there's nothing else different in a mechanically ventilated patient than the usual type of routine practice of enteral feeding.
Thank you very much, sir. There are lots of questions coming in, but again, we have one more session by case study by Swaha, dietitian. So over to Swaha now. Thank you very much, sir and ma'am, for the elaborate and informative session. There are a lot of thank you messages coming in, and if we have few more questions, we will raise to you, and probably we can send them by mail the replies they need. And now over to Swaha, our dietitian, a case presentation on nutritional management in critical care.
Okay, they want us to stay on it. Just move a little bit closer. I must mute myself.
Hello everyone, good evening. Am I audible to you? So I am starting my today's session. Today I am going to present a case on nutritional management in critical care. So at first I will just give one brief introduction about my case study. So my patient got admitted to our hospital for bladder cancer and prostate cancer as well. And patient was suffering from high-grade bladder cancer. So not only that, patient has different comorbidities. That patient was an obese patient, and with that, during the time of admission, patient got septic shock or sepsis as well. And patient got like acute kidney injury or AKI, or we can tell that condition as rhabdomyolysis also. So as per different aspects, we planned the nutrition and how you proceed. So that only I will give one brief introduction to you. So as per prevalence, we can see one study by 2018, males are more prone for bladder cancer from the females. And we can also see that worldwide, the bladder cancer is 7th most common cancer. And bladder cancer has some risk factor as well. It also depends like age, gender or race, and it's also dependent with like chronic bladder inflammation. If someone get again and again, then it will be one high risk that they will get bladder cancer also. And smoking is also one main cause for that. So now I am coming to my case scenario. Here the patient was 65 years old male, and he got admitted in our hospital on 2nd of March and got discharged on 25th of March. Patient food habit was non-vegetarian, and surgery was done on 4th March. And we did get robotic assisted radical cystoprostatectomy. And one emergency surgery also we planned, that is laparotomy, that is on 14th March 2020. And patient past medical history was patient undergone TURP and TURBT on September 2019. So I will just tell the diagnosis of the patients that are adenocarcinoma, that is high grade cancer in urinary bladder of the patient, with that prostate cancer also there, and as well as incisional hernia is there, small bowel obstruction was there, septic or sepsis shock patient suffered, and severe respiratory distress was there with diabetes and hypertension. So as per the anthropometric details, you can see that patient was obese. So we planned her calorie or protein according to that. And patient chief complaint was patient was suffering from micturition again and again, and some difficulty for passing urine as well. So through my nutritional status, patient at SGA, it came patient was well nourished, and we did one pre-surgical nutrition counseling as well for the patient. In that, we find out that patient, in dietary recall, 3 days dietary recall average, patient was taking 1,800 kilocalorie with that 35 gram protein. As far we can see in his diet, protein was extremely low. So we suggested one high protein oral nutritional supplement for the patient to build up before surgery. And after that, we fixed one calorie protein for the patient, what he maintained. So we have different medical nutrition therapy goals or MNT, that is to achieve and maintain a healthy body weight for the patient and prevent and reduce nutrient deficiency. As per the prolonged hospital stay, micronutrient deficiency is very common for the patient. So we have to take care for that also, and preserve lean body mass and maintaining the strength and energy for the patient. With that, improve tolerance to treatment, reduce the risk of cancer recurrence, the development of another cancer, and maximize the quality of lifestyle and physical activity. And with that, we suggest to the patient one high protein, high calorie with optimal vitamin, energy, and antioxidant intake also. So we can see, as per the recommendation of Clinical Dietetics Manual 2018 second edition, that the energy requirement for the normometabolic patient is 25 to 30 kilocalorie, and as per hypermetabolic patients, it is 30 to 35 kilocalorie per kg per day. But here in my case, patient was obese, so here we took that criteria, that is 21 to 25 kilocalorie per kg per day. And in protein, we can see for non-state patient, it is 1 gram to 1.2 gram, 2 gram per kg per day, and undergoing treatment will be 1.2 to 1.5 gram per kg, and hypermetabolic state, we have to give 1.5 to 2 gram per kg per day. So when we have to start TPN, as per a critical case I am presenting here, and in my case study also we started TPN. So there are a few indications when we have to start TPN. So I will share the indications now. That is prolonged ileus if more than 5 days, short bowel syndrome, severe malabsorption, excessive time to enteral feeding or oral feeding, recurrent regurgitation, and insufficient energy intake. So if you have these indications, you have to start TPN as well. So in that case, why I am presenting that case? Because this case is very interesting from nutritional aspect. Several nutritional aspects, this is interesting. That is the pre-surgical nutrition counseling we did here for the patient, and we find out what is the mistake and we rectify it. Next, ARAS protocol we followed for the patient, and patient was undergone EKI. So we managed that also. And after that, post-surgical nutrition management and sepsis. So different nutritional aspect was there. That's why the case is very interesting. So as per in our biomedical data, I can tell you what is very important. I just round up here. That is, you can see the urine and creatinine level went very high, and we have to start dialysis also in that time. So we just modify his diet according to that. And what is the nutritional requirement we follow here? That is, initial stage as a obese patient is prescribed, we get 21 kilocalorie per kg body weight, and we give 1 gram. After that, in final stage, as patient was undergone sepsis or septic shock as well, we increase the protein, how much patients intake, that is 1.5 gram per kg per body weight. And as per ISPEN guidelines, we can see all patients who are not expected to be in normal nutrition within 3 days, they should change it to TPN within 24 to 48 hours. And we can also see here that ICU patients should receive 25 kilocalorie per kg per day, and slowly we can increase that. And multivitamin or trace element should be there in the TPN, as far we can prevent the micronutrient deficiency from the patient. So here I am coming that nutritional care plan for the patients, where we can see in day 1 patient come and got admitted in our hospital. So we gave as like diabetic, low salt, low fat, low protein diet. What we already planned in pre-surgical counseling, and patient was already in ONS. So we continue that thing. On second day, after evening 4, 5 or 6 o'clock, we started liquid diet for the patient, and ONS was continued as per same. And we give ERAS protocol also for early recovery enhance after surgery. As well, we gave 50 gram of carbohydrate supplement 8 hours and 2 hours prior surgery. So when we are coming on next day, patient was in BM, and day 3rd was the surgical day. Day 4th to 5th, patient urine output was very low and no peristaltic movement was there. And as per I can note it down also in the biomedical data, you can see. So patient urea and creatinine was elevated. So we started hemodialysis as well on 5th of March, and after that also urine output was not increased. So on 6th of March also patient was undergone dialysis, and after that urine output also increased and kidney also worked normally, and we can find the mild peristaltic movement also on in patient. So on day 7th, we started clear liquid diet for the patient, and patient tolerated. So we slowly progressed to the diet. On day 8th day, we changed it to normal liquids, and we started ONS also continued like same. So on 9th to 12th day, we changed the liquid diet to semi-solid diet as per patient toleration, but the oral nutrition supplement was continued. On day 13th, morning we gave patient liquid diet, and after some time patient was suffering from fever, vomiting and abdominal pain. So for that patient was in liquid diet, and we took the patient into CT scan. After CT scan, we find out that there was some defect in interior abdominal wall. So after so we took the patient in like emergency laparotomy surgery. After surgery, we started on day 15 TPN. So we started with 30 ml, and slowly we progressed it to 45 ml of TPN, and slowly we increased more. So on the day 16th and day 17th, we increased the calorie also, and we increased the volume of the TPN. As per we see, the toleration was good for the patient, so we increase and we stay the same kilocalorie and same protein to day 18th and day 20. But day 19th and 80, we tried like little oral sips as per patient psychological satisfaction, our patient tolerating or not, and we saw that patient tolerated that. So as per, and peristaltic movement was also coming in normal form. So we started again liquid diet with wellness on day 21st. So on day 21st, we started when the normal normal oral liquid diet. We can see patient undergone asepsis or septic shock. So for that again we increased the energy requirement, and after that we made it that from 1 gram to 1.5 gram. So on day 22nd, 23rd and 24th, we can see the patient requirement we fixed as a 1.5 gram protein to 1 gram. So on day 22nd, patient was in full liquid, normal liquid diet with wellness, and day 23rd, we just changed it to semi-solid diabetic diet. On day 14th, we changed it to soft diet. So slowly we progressed the diet, and patient was tolerating well. And we fixed our energy to 25 kilocalorie per kg, and we fixed our protein as 1.5 as per patient was sepsis, and after post surgical case, we just fix it at 1.5 because previous because of the like acute kidney injury was there, so we fix it at 1 gram. And now after like several times, it just came down also our creatinine and urea in blood, so we just start it to 1.5 gram of protein. As per discharge note, the patient got discharged in moderate amount of calorie with high protein diabetic diet with low amount of salt and fat, but high potassium rich diet. Patient got discharged because that time, as per biomedical data, patient potassium was very low. So we review after 1 week to the patient, that time potassium came down, so we changed it to again normal amount of potassium. So how much energy we achieved, you can see here. So as per our target was there at last, it will be 1.5. So as much 80% to 90% we can recover, we can cover through energy, and in protein also same. As per our target, we can achieve that as per the full time. But when you can see that on day 3rd to day 6, that time we can't start anything because of the patient condition. And day 14 also patient undergone through emergency laparotomy, so we can't start anything. After that, we just try to achieve patient calorie and protein, and we do that. Thank you. Thank you. You can ask me if you have any doubt like related to this topic. We will just take that. So one question came here. How to calculate protein for renal patients in high urea and high creatinine but low albumin. So for the protein criteria for renal patient, as per patient was suffering from acute kidney injury, you have to calculate 0.8 to 1 gram we can give for the patient. And as per the patient condition, patient body weight and height, we will just plan that.
Can I make a comment, Swaha? Can't hear us. Hello, can I make a comment?
Yes.
Hello? Thank you. Thank you.
Thank you, Swaha, for the nice case presentation. So today's session is coming to an end. I want to thank all the delegates all over the world for attending this first day webinar. And tomorrow at the same time between 4 to 5, we are having the next session by Ms. Meenakshi Bajaj, leading dietitian. She's the head dietitian of Omandura Multi-Speciality Hospital. And we have Ms. Dr. P. Nazni, professor and head Department of Nutrition and Dietetics, Periyar University, who are going to give their valuable speech tomorrow. And at the same time, we at the end of 3 days session, you'll be provided with the certificate. So we request you all to attend all the 3 days session. And the user ID and password for each day's meeting will be shared on the Curie website. So we request you to log into the Curie website for each day's user ID and password. And for any queries, we would request you to contact our coordinators, Ms. Swaha and Ms. Chitra. Thank you, sir, ma'am. And Sriram, sir, you want to say something? So
yeah, can you hear me now? Yeah. Very quickly, yeah. I think we should all congratulate Swaha on the phenomenal job she did in the nutritional management of the patient. It is as good as any European hospital or North American or Canadian hospital, you know. Fantastic job, and this is only one of the many successes of Curie Hospital.
Thank you very much, sir.
Okay, so
thank you very much, sir. Thank you for your valuable time.
And then I also tell the audience that any questions that they may have, if they can route it through you or through Swaha, we'll be very happy to manage, because the success of the CME program is that the speakers must be available for at least 6 months after the CME program is over. And any papers that you might need, I'd be very happy to send you the original papers, whatever is not available for free. Both Chitra and I are at your service.
Very sweet of you and very kind of you to say that, sir. So, madam, you want to say something?
It was a pleasure to have participated in this webinar. Thank you.
Thank you very much, madam. So, any queries, we will route it to you through Swaha or Chitra, sir. So, looking forward to many more webinars with you. Thank you very much, sir.
Thank you.
Thank you.
Thank you, participants. Bye-bye.